I did put a disclosure slide in there. So I have research support for full disclosure from Janssen for OCD, Endo for stuttering, Forest for autism, Otsuka for Tourette's, Cato for Tourette's, TSA for Tourette's, NARSAD for pandas, NIMH for OCD and autism, CDC for Tourette's, Yale for Tourette's, and All Children's Hospital for autism. And I get about $200 a year in book royalties, and I'm on the TSA Medical Advisory Board. So what I was going to go over is we did the guidelines a few years ago for OCD and Tourette's. So I'm going to kind of quickly go over that literature. Not a lot has changed. Talk a little bit about aggression, which Dr. Collis did a pretty nice job of that already. Looking at epidemiology of aggression in these groups, and then some of the medical and behavioral treatments. I always like to look at, because one of my things that I try to teach the residents is not just like what the symptoms are, but I really like to get the quality of when did they start, why did they start, how did they start, how long they've been going on, did they go away, what makes them worse. So I really look into the ins and outs of the different types of repetitive behaviors, and I think that gives me some diagnostic clues. So the incidence of these disorders, they're actually fairly common. About 2% of children will have an obsessive compulsive disorder. Got upwards towards 1% of children with autism have autism, especially the boys. Tics, it varies depending on the different studies. There's some studies that suggest about 2% have a chronic tic disorder, 1% with Tourette's, 5 to 20% with transient tic disorders, and then there's some that are like 1 in 1,000. So it varies depending on how the data was gathered. Trichotillomania is about half to 1% of the population. Skin picking is pretty common at 4%, and stuttering is 1 to 2%. Consequences of repetitive behaviors, if they have like picking or severe tics, they can have like scarring, or I've seen kids with cervical injuries because their tics are so severe. Kids that have trichophagia, trichobezoars, we've seen some kids with that have had to have surgery. Dental problems from picking and biting and various types of tics. Psychological effects are huge, and these kids feel different. They get picked on a lot, and they often have a hard time integrating socially. They often avoid social situations. I've had girls that were excellent soccer players that refused to play soccer anymore because when they were out on the soccer field they were ticking so badly. So these are, it really narrows their life, and for reasons that really I think is unfortunate. And I don't think you guys have this, but I had pictures of trichotillomania, skin picking, untreated OCD, and tics. I know the DSM-5 is coming up, and I don't think they're really changing a huge amount in the tic disorder criteria. The main one they're going to change is transient tic disorder. They're going to call it provisional tic disorder, with the idea that you don't know until a year's gone by whether they were transient or they're going to be chronic. So it's going to be called provisional tic disorder. Chronic motor or chronic vocal, where they have only one or the other and never had both at some point during the course of their illness. And Tourette's disorder, and I'll use Tourette's syndrome mostly, but I know technically it's supposed to be called Tourette's disorder. I'm just stuck with the old terminology. Motor and vocal tics occurring at some point during the course of their illness. They don't have to have them both at the same time, but at some point. And then tic disorder, NOS, for the garbage bag terms. Simple tics, vocal or phonic, or sniffing, snorting, throat clearing, grunting, humming, barking, screaming. Simple motor tics are what we mostly see is eye blinking, shoulder shrugging, nose wrinkling, mouth grimacing. Complex tics, that's when they start saying something that seems to resemble something like a phrase or a word. Coprolalia is when they start cursing. That's actually pretty uncommon. Palilalia is when they repeat themselves, and echolalia is when they repeat others. So sometimes you might see somebody that has echolalia and you wonder, is this autism? In some cases it may be tic disorder. Motor tics are coordinated sequential movements that are complex. Like I had one kid that was a watch looker, It could be tapping, touching, counting. And they can seem purposeful, and the thing that really gets tricky is sometimes they're really hard to distinguish from compulsions. They did this sort of survey, Freeman in Canada, and they looked at copra phenomenon in 505 Tourette's youth, and found that 20% had coprolalia, 50% in the females, 20% in the males, and coprapraxia, which they're using obscene gestures, and it's usually crotch grabbing or shooting a bird, something like that, and 6% and 5% of females. Typically onset's a little later, at age 11, usually about 5 years after the onset of the other tics. And this one, I don't know if you can read very well. It's the comparison of youth with and without copra phenomenon. And the main thing I wanted to point out there is that that these children have a little bit more anger problems. They have the copra phenomenon. They have typically a little bit more ADHD, typically have a little bit more severe tics, but much more likely to be on medications if they have this. Age of onset of tics, and this is actually a thing that's interesting. It can be any time before the age of 18, but when we look at some of the data, especially like some of the recent CDC data and data that I'm doing with the FMHI Medicaid database, there's a huge number of these children having onset before the age of 4. And we're seeing 2 to 4 is a really, really common age of onset of the tics. So this is actually before they've ever been tried on stimulants and things like that people previously attributed to tic onset. So back to this CDC study that Larry Scahill was the PI on. This is where they used the National Health Survey data, and they surveyed 64,000 and found 225 with a reported diagnosis of Tourette's. So it ended up being about 3 out of 1,000 school-aged children. The thing that was interesting, it was twice as common in the white kids compared to blacks or Hispanics. And actually, I see this in my clinic, and it's like, when you say this to, NIMH when you're writing grants, it's like I just don't see it a lot. Not that we're, selecting against them. So it'd be interesting to see if that holds out in other large studies. But we do see that in the clinic as well. Most cases are mild. About 1 out of 4 kids with Tourette's have more severe symptoms. Boys have 3 times higher rate than girls, and about 80% have another diagnosis, mental illness or developmental disability. Okay, so this was the CDC study that I was talking about, and over 60% had ADHD. Fairly significant part, about 30%, had developmental delays. And usually when we see this as language disorders and coordination disorders. And about 40% had behavioral or conduct type problems. Tic characteristics. This is one of the things that I think our kids with tics really struggle with, is because they kind of come and go in various settings and certain circumstances, and the teachers will, of all people, will be the ones that are the hardest on them. Oh, they're just acting out, they can hold it, they can suppress it. And that's not always true, and that's actually how we measure tic severity, is how well they can hold off their tics or suppress their tics. Some kids are better than others. Tics change quite a lot over time. They get worse during anxiety. Sometimes they get worse during periods of relaxation. And a lot of them have premonitory urges. And this is actually what we capitalize on when we use behavior therapies for kids with tic disorders. And it's kind of a urge or itchy feeling that they'll describe often in the muscle group just before the tic starts. And it's kind of like, if you think about OCD, it's kind of that obsession. But this is sort of a sensory motor obsession, if you like it to that. And then they tic, and it sort of relieves that urge until the urge builds back up, and then they get it again. So that's sort of the background of tics and OCD. Well, for management, for tics, a lot of times, if they're mild, it's mostly reassuring the parents that this is not really a big deal. It's not really causing them a lot of impairment. You have to look at how much they're being teased, if they're having any issues of pain. Is a symptom causing them to be distracted and not do as well in school. And then you start with whatever's causing them most trouble. And because a lot of these kids have comorbidity, I would argue that a lot of the times you start with a comorbid condition. We're doing habit reversal